Good morning and good afternoon to our distinguished speakers and members of CCA in the audience. I'm Flori Lazier, President and CEO of Corporate Council on Africa, the leading U.S. business association focused solely on connecting business interests on the continent. I want to thank all of you for taking the time to join us for today's panel discussion titled Accreditation and Accelerating Progress Towards Universal Health Coverage, UHC, a critical role for the private sector. This event is part of CCA's U.S.-Africa Health, Security, and Resilience Initiative. The initiative brings together major U.S. and African leaders, corporations, multilateral organizations, foundations, and other health sector stakeholders to collaborate on developing policies, promoting strategic partnerships, providing critical Africa health-related information, and facilitating investment to strengthen Africa's health security. We are delighted to host today's panel on advancing the role of the private sector and accelerating progress towards achieving UHC goals in Africa through accreditation, quality assurance, and continuing professional development. We are grateful to have leading voices and champions from the continent and the United States to guide us through today's discussion. To moderate today's panel, I am delighted to introduce Eckhard Kleinau, who serves as University Research Company, URC's Director of Research and Evaluation on USAID's Human Resources for Health program. Before I turn it over to Eckhard, I want to go over some housekeeping rules for the question and answer period. First, please use the Zoom chat function to send us your questions. We look forward to asking them should time permit. We will only take questions from those who have provided their name and affiliation. So don't forget, when you're putting in your question, make sure to put in your name and your affiliation. So without further ado, let me welcome Eckhard Kleinau. Eckhard, take it over.
Thank you so much, Flori, for the introductions. And as Lori said, I am working with the University Research Co, URC, and have been with them for a number of years, working in various capacities, mostly in research evaluation. Today's topic about accreditation, universal health coverage, and quality of care, and especially the role of the private sector in this context, begs the question, can we have universal health coverage without also having high quality health care? We know about many initiatives in Africa and in other continents to improve the quality of care. But a great challenge has been moving from small initiatives to scaling up and providing cost-effective solutions to quality improvement. And when we look across the continent, we also find that there are very few facilities that actually meet the gold standard of care as it's defined by the process of certification and accreditation. And some of those who do the accreditation and certification we have on today's roundtable. From both ends, those who have been certified and accredited and those who do the accreditation. URC specifically, to give you an example, has also been involved, and we recognized long ago that it is important to have a process and a body in place for countries to have a body in place to do the accreditation. So in our case, we had helped Jordan to establish the Healthcare Accreditation Council. And so we helped to establish it, but also to build the capacity of the council. And we're happy to say this is a body that's still going very strong. It is accredited by the International Society of Quality in Health Care. And it's also a nonprofit organization. And it may resemble in many ways one of the organizations that are present in our roundtable. Our panel will address some critical questions. I mean, one of the fundamental questions is, why should we care about accreditation? When does it matter? To whom does it matter? Should all the facilities be accredited using international standards? And what are some of the alternatives? Some may say, well, the standards are too high. So should we lower the standards? Is it acceptable in order to scale accreditation and certification on the continent? And as I mentioned earlier, we need to define the roles and responsibilities. What is the role of the private sector, the public sector? What should they do? What shouldn't they stay away from? But accreditation and certification for healthcare providers is certainly not just is not only a single solution. There need to be important enabling factors at play as well. I mean, I'm talking about things like continuing professional development, health insurance, and what about providing credit to health facilities so they can actually improve the quality and go through the process of accreditation. Our panel will talk about solutions. They will also talk about, hopefully, about challenges and success stories. And while we have only a limited amount of time, we all have a website, right? So go and find some of these stories there in addition to. So I would like to start with our first panelist in terms of introduction. That is Jackie Stewart. She is the CEO of the Council for Health Service Accreditation in Southern Africa. The acronym is COHASA. Our next panelist is Dr. Mohammed El Sahili. He is the CEO of Medland Hospital Services, which is a private provider in Lusaka in Zambia. Our third panelist is Nicole Speaker. She is the Director of Quality at the Farm Access Foundation, which is headquarters in the Netherlands, but with offices in many African countries. And our fourth panelist is Dr. Edgar Kalimba. He's the Deputy CEO of King Faisal Hospital, a very large public hospital in Kigali in Rwanda. We had 5 panelists, but our last panelist had to send his regrets for today. Dr. Torkmor Maruta from the Africa Center for Disease Control in Addis Ababa. He was called on an urgent mission to Namibia to look into laboratory accreditation and the impact of COVID, unfortunately. So we have 4 panelists for today, and we will still have a good discussion, and also we will touch on the last subject, laboratory accreditation as well, because our speakers have experience in this area as well. As Flori has said earlier, remember, please, as you listen to the discussions, please enter your questions in the chat, identify yourself, and we'll either take up the question immediately by the panelists or we'll address them at the end of the roundtable. So without further ado, my first question to all the panelists is about accreditation, quality assurance, an important element towards achieving universal health coverage. So what is the critical role, especially for the private sector, as many countries in Africa work to improve the quality of care? How important are certification and accreditation for achieving universal health coverage? They alone can't do it, but are they an important component of it? And what role do panelists see for the private and for the public sector? What should they do? What they should maybe stay away from? So that's my question to all 4 of you. And let's start the videos. And let's start with Jackie. How about giving us some of your perspective to this question?
Thank you, Eckhart. It's great to be here on the panel with you. An important question. I think the private sector has an increasingly important role in Africa. We know that in many countries, our public sectors are struggling. And I think what is really important is trying to get more public-private partnerships and more cross-fertilization between the sectors. I'm told many times that accreditation is not there for the public sector. Well, Edgar's Hospital is a prime example that a public sector hospital can achieve and can maintain accreditation. And I think importantly in Africa, if we really want to have universal health coverage that is of good quality, there is no point in my mind increasing access to bad services. We must ensure that we increase access to good services. And the better the quality, the better our health outcomes are going to be, and the better our population is going to be served. And I believe that accreditation offers us that aspiration that people can work towards it. It may not happen automatically, and it certainly will take longer in more resource poor settings, but there's no reason why people cannot aspire to accreditation. And I think to have an external evaluation that assesses the quality of your services and gives the public some reassurance that they have at least met thresholds across the board. And we're not talking about individual services, we're talking about whole healthcare facilities. And that for me is important, that it tells you that the services are good, it tells you the staff are properly credentialed and are working within a policy framework against standard operating procedures that allows them to function well. And that for me is the critical part, that accreditation should help the facility to be well managed, that enables the clinicians and all the people working within it to work to their optimum effect.
Great. I think those are some really excellent points. And let's get the perspective of those who may consider accreditation. Dr. Mohammed, how about you going next?
Thank you, Eckhart. I must agree with Jackie with everything that she mentioned. In fact, Medland Hospital has been in contact with SASA right before the opening of the facility, because I do believe that each facility, each healthcare institution has to also take into consideration an accreditation to implement standards. And what Jackie has said in terms of maintaining those standards is very important, because it's easy to implement and to be accredited, but then to maintain that accreditation is the most workable challenge. However, unfortunately, we were hit by the COVID pandemic, and that has delayed our project. However, we have not stopped trying to implement as much as we can what we have learned through the discussions with Jackie and her team and other players as well. Why so? I think the answer is with the COVID pandemic. We have seen that during pandemics, what we lack as institutions and what we must put in place as in first stage is how to organize ourselves to still be efficient, professional, despite all the challenges that the crisis may have or may be hitting us with, and at the same time to be able to work with a number of cases or patients or services that we were not dealing with in the past. And for that to happen, we have to have a team that has this established in their mindset, established in their daily operations, and you can only reach that through implementation of standards and through a proper and recommended accreditation.
Great additional points, Mohammed. Thank you. And just listening to both of you, I mean, the importance of the impact of the COVID pandemic, but also what Jackie said about not lowering standards. You want to be assured that you are getting standard care, but we have many health facilities that are far away below the standard. And Nicole, what would be your take on the question? I mean, sometimes it makes it sound like accreditation is either or solution. Either you get it or you don't get it. But that may not be the only way. And I'm not suggesting, Jackie, that's what you said. I'm just trying to make a bigger contrast here between what is the ideal and what is maybe a more practical solution. Go ahead,
Thank you
Nicole.
very much, Eckert. And first of all, thank you for the organizers for inviting me and inviting all of us on this extremely important topic. In fact, you mentioned universal healthcare coverage. And when we talk about universal healthcare coverage, we often talk about insurance or contracting or payments, but we talk about addressing the barrier of access. When recent great reports of World Bank and WHO and OECDs are clearly showing that poor quality of healthcare is causing more annual deaths than lack of access to care. Now, these are numbers that, you just sometimes need to sink in. It means that we're sometimes proactively killing more people in a hospital than outside the hospital. So it means that it's the biggest barrier that we need to work on in order to achieve universal healthcare coverage. 50% of people in Africa, rich or poor, go to private healthcare facilities, especially because a lot of them are accessing private healthcare facilities in informal settlements, which the government doesn't always recognize. And it's private initiatives and faith-based facilities that fill a very important need, especially when it comes to lower income countries now and lower income groups. Now, I'm all in favor with my other panelists in saying we should never lower standards, right? I think the only reason why we accept it is because the people who define the standards go to the nice upmarket hospitals or get on a plane and go seek healthcare somewhere else. And the ones that are more vulnerable are stuck with lowering the standards when everybody should have access to basic healthcare provider. Accreditation models are a great way of recognizing excellence. And we're having a panelist, some great people who really serve as champions of centers of excellence, leading the pack when it comes to quality improvement, but also recognizing that in a lot of remote healthcare places, healthcare facilities will not be able to meet the standards because the environment don't allow them to meet those standards. Challenges in HRs, challenges in infrastructure, challenges in basic needs like water and electricity. But as a result, there is very little known between licensing and accreditation. There's a gap there where we don't know what the scale, scope, and quality of care is. And whether you are a patient or a contractor or any other healthcare sector stakeholder, it's also important to know who's almost there in accreditation, who has been able to improve on their trajectory towards quality improvement as they go to this status of excellence. That is something that we have done. And actually, I really want to recognize COSASA because they've been part and parcel of developing this process together with Joint Commission International to have a guided way towards excellence, where ultimately, let's be realistic, we all want healthcare facilities to be accredited, but guide and recognize incremental steps towards that achievement. Also recognizing that for certain healthcare facilities, on a scale from 1 to 5, getting to scale number 3 is probably the best they're going to be in a while, but you are able to recognize who is the best of the rest despite the challenges that they have. Instead of lowering the standards, you identify the gap on achieving excellence, and you can manage and allocate your resources accordingly. And you can also start regulating those healthcare facilities that don't make any changes at all. And this is where regulation and not just incentives need to come in. So what we're advocating for is, as you start driving quality improvement, already make quality improvements part of a formal recognition system that recognizes steps achieved, so that when you start building a pipeline, that healthcare facilities can fill up, and accreditation bodies like COSASA can come in and recognize certain centers of excellence. So we need solutions for resource restricted settings, but those solutions should never be about lowering the standards.
Thank you for making that point, and glad to hear that this is also a point that Jackie and Mohammed made. What about King Faisal Hospital, Edgar? and if you could unmute yourself. How about the process that King Faisal went through? How long was the journey? And I also wanted to congratulate you. I mean, you just got accredited for 4 years by COASA. That's quite an achievement. But getting there, tell us a little bit more about that, also in the context of universal health coverage and really the role you see for the private sector. Thank you.
Well, thank you very much, Ekad. And again, I appreciate the opportunity to be on this panel. I hope you can hear me loud and clear, all the way from Kigali, Rwanda. So,
excellent.
Yeah, so I think my fellow panelists have already expressed very important points with regard to the discussion. I mean, we cannot speak about universal healthcare, realistic universal healthcare, without speaking about quality. It's basically access and quality. I think Jackie put it very well, that you don't want to increase access to poor care. So access really goes with quality. So in a lot of sense, at least for the experience of King Faisal Hospital and generally the experience here in Rwanda, accreditation for us definitely has been a very, very powerful quality enhancing strategy. I often hear clinicians who practice at King Faisal Hospital and have, sessions or practice at other hospitals as well that are not accredited. The experience is completely different. When you work in an accredited hospital like ours that has been in this journey now practically 15 years, although we've been accredited since 2011, it begins with even the mindset of the doctors, the nurses, the allied health professionals. It impacts every aspect of the institution. And, quality and performance in general in healthcare, there's a lot of mindset and corporate culture that comes into play. So for us, sometimes, it becomes ubiquitous and people don't realize the impact of being accredited, but we know that beginning from the mindset, how things are done, that directly impacts the quality of care that we give to our patients. But I think also from the overall governance, compliance, risk management, operational, financial fitness, the whole process impacts every aspect of how the institution runs. So I think, one of the panelists mentioned that that most of the times public hospitals, given the huge issues and challenges and that we face, they tend to struggle to be accredited. I would say that public hospitals need to be accredited more than even the private hospitals, because the private hospitals tend to have more resources, the quality is spontaneously better, but the public hospitals struggle with everything across the board. So we are the ones that should actually be much more keen to be accredited. And the role of the private sector is obviously extremely important. In our case, obviously, we are accredited by COSASA. We are actually the only hospital in Rwanda that's accredited by a regional or international body. But then if I give the example of Rwanda in terms of universal health care, which we've taken huge strides over the last 15 to 20 years, one of the key drivers has been what we call community-based health insurance. 80% of our people live in the rural areas, and access and quality has been largely driven by a lot of investment, yes, but also the Mutuelle de Santé, which is a community-based health insurance that covers practically more than 80% of the population. And part of the funding of this is actually privately funded. Everybody contributes to this. The private insurance contributes, everybody who is working contributes. There's a percentage that gets to fund it through VAT. So that's just one example of the role of the private sector to drive universal healthcare. And the journey for us started about 2006, but it took us about 5 years to basically get to a point where we got accredited for the first time for 2 years, which was in 2011. And since then, we've been reaccredited a few times, and we've never had a break or a halt. I think it's Dr. Mohammed that mentioned that, you can sort of work hard, get accredited, but maintaining becomes a challenge. It almost becomes like putting makeup at the beginning. You're trying to clean up, you make yourself up to pass the exam, and then maintaining becomes a challenge. But I think for us, having been accredited for now practically 10 years, it has become really a mindset change. It has become a culture. Obviously, there's always continuous work that has to go in to make sure that we maintain the standards. Every time we come towards either a midterm survey or towards the end of the accreditation period, there's a lot more work. We sort of have to wake everybody up again and make sure that everything is aligned. But it's possible. We are a public hospital. It's been 10 years and it's amazing. It's been one of the best decisions, definitely.
Wow, that's a very positive statement. Thank you, Dr. Edgar. That was excellent. And you mentioned a couple of things. It's not just the accreditation itself, but also there is an enabling environment. You mentioned health insurance, for example. Let me come back to Jackie. From the perspective of an accrediting organization, what other elements do you see in place? And if you could respond to two things. So it's the enabling environment, but also I think what Edgar mentioned, accreditation is a process. Talk a little bit more about that.
Thanks, Eckhart. Yeah, I mean, I think the enabling environment is probably, as Edgar has said, particularly critical in the public sector, because in the public sector, many of the decisions are outside of the control of the hospital. So, for example, in some countries, the Ministry of Health will be responsible for all the the major human resource decisions of professionals, doctors, nurses, allied health professionals. They will be responsible for the capital budget, the investment in any equipment or any structural changes. And we have seen hospitals that have done everything they could do, but they have not been able to get accredited because their generator wasn't replaced, for example, because the ministry either didn't have the budget or it wasn't on the priority list. And those structures, again, some of the ministries of health do not have a maintenance team. All the maintenance is carried out by another ministry. So you've got to make sure the priorities of different ministries are lined up to create that environment that says we're all going to work together to ensure we create an enabling environment that will help the hospitals not only achieve accreditation, but maintain. And I totally echo what Mohammed has said. Getting the first step it's not easy, but it's relatively easy, but maintaining it is really important. And each time you're reaccredited, the gap between where you are and where you want to be is smaller. So demonstrating that ongoing improvement is more difficult. When you started at a base of, let's say 30 out of a potential 100, and you've increased by 70 to get there, everyone can see it, but that maintenance is important. And that comes down to the culture and the mindset and the whole belief in a continuous improvement process. And then to come onto the process, there is a risk that people see it as a paper exercise, because obviously we need documentation. Now, we don't mind if the documentation is on paper or in a computer, as long as there is documentation, because you cannot run a healthcare facility without standard operating procedures, without policies, without job descriptions. And if at the beginning of the process, those documents are not in place, you've got to start putting them in place. And that's where people think it's a paper-heavy system. But all of us who've been through professional nursing, medical, allied health professionals training, know we were all trained to do accurate documentation. So once those documents are in place and people become familiar with it and use them, it's not about having a folder on the shelf that gathers dust and comes down once every 3 or 4 years when the accrediting body comes around. It's about real life documents that are used, that are updated, that are modified, and that we can see that everyone uses the same procedures. And we've got standardized procedures throughout without ever compromising the ability of clinicians to make decisions on the spot because a particular patient has something different. So those processes are important. The processes as well within the facility, how things are done, whether it's a clinical process or it's a maintenance process, that they're done and they're done regularly and they're systematized. And today I was in a conversation with a hospital. They're not yet accredited. They're in the process and they were just trying to book their slot for when they can have their survey. And they have said the process of preparing for accreditation has already had a major impact on the sentinel events in the hospital. And they can directly relate that to entering the accreditation process. So I think it's those processes that actually make you do the right thing first time and do the right thing when no one's looking, or what make this a really quality process and that everyone should buy into.
That's an excellent example, Jackie. Thank you. So, Mohammed, from your perspective, how does that resonate? I mean, have you, my understanding is you have taken steps towards accreditation. What Jackie just said, does it resonate? Certainly it resonates with some of our audience today. We have some comments there.
It does. In fact, because I think the best learning period is the preparation for the accreditation. It's where we are facing processes or protocols, SOPs, whatsoever, that we were not maybe taking into consideration, but building that culture within the team, also that culture that you are sharing with your patients indirectly. Patients, they will have to learn a little bit about how the hospital is servicing them, how the facility is bringing in an accessible, affordable medical service to them. And it's not easy because also there is that trust part. There is the fact that people may think that when you implement new standards, this will be an additional cost on services, which may be the fact, but we have to, as a facility, to absorb that cost. And I think this is one of the barriers also from a public sector perspective, less probably from private sector perspective. The cost of that you have to invest in order to be accredited is not something that many boards take into consideration, at least not when they bring in a new facility, and surely not after spending 5 or more years in business, and they think that everything is smooth and everything goes well. And guess what? When a crisis hits us, this is when we start saying, oh, but how do we do? How do we address such an issue? And this is when you will see that probably because we did not work on a culture, on an enabling environment within the facility, not only within the investor shareholders or other players, but within the facility itself. And this is also, I would like to share one of the experiences that you may face, at least that we faced at the beginning. Sometimes, because some teams are coming from different other institutions and they have different experience levels, you will see that within the same facility, between departments, there is a difference in the level of service that you are providing. And you will hear that from your patients. Oh, but in that department, I feel more comfy, or I feel better, and that is the culture we are talking about. And that is why you need to be accredited, so that you align the standards horizontally, vertically, and it becomes a one facility rather than different departments under one facility. And here I have to say that what King Faisal team and Dr. Edgar, because we have learned from their experience. I mean, it's there, it's shared in many of the forums, and I think coming from a public sector telling us how important it is with all the challenges that they have faced, I don't think that us as private sector, we have excuses to share for not being accredited. COVID-19 is a good excuse, but I think that also Jackie has found and her team, they have found a solution for that. They have digitized their survey platforms, etc. And I think this will facilitate on all of us now that we know how to cope with a crisis such as this pandemic.
Oh, that's an interesting aspect. Hadn't thought about that. So, Jackie, it sounds like you can do the surveillance virtually rather than sending out surveyors to the locations itself?
We can do an interim survey. So in the midpoint of the accreditation, we can do that digitally. With an external evaluation, you need at least one person on site. Because one of the key elements of accreditation, you need to feel the hospital, you need to feel the atmosphere, the culture, and you cannot feel a culture remotely. So we've got what we call a hybrid version where just one person is on site and the others are remote. Okay, interesting. Thanks for sharing that. Nicole, I wanted to come back to the enabling environment, and Edgar mentioned it, Mohammed mentioned it, Jackie mentioned it, but what does farm access do specifically? Two specific questions. Tell us a little bit more about SafeCare, one of your signature products, but you do several other things. And Edgar talked about health insurance. We just talked about the costs of accreditation. Where do facilities, especially public facilities, find the financing for it? So say a little bit more also about the enabling environment. So SafeCare and all the other things that go with certification accreditation.
Yeah, thanks, Eckert. Yes, I think I've been doing this work for a long time now, and I sometimes speak with quality people and I sometimes speak with finance people, but somehow you never meet in the same room. And I think that is a fundamentally wrong assumption. First of all, let's be clear, we need to do better on quality, right? And I've heard my fellow panelists talk. This is about making sure that the do no harm principle, but healthcare facilities continuously strive towards excellence and doing the right things and continuously improving health outcomes. Having said that, in most countries where accreditation systems are functioning or relatively functioning is where there is a relatively mature healthcare system and basic insurance systems are in place. So in the Netherlands, where I'm originally from, we have mandatory health insurance. Accreditation is a requirement to be able to contract for insurance. And as a result, it's become almost a mandatory process in itself, right? Because most people will access it through health insurance. You see countries like Rwanda, I'm really glad that Dr. Edgar is here, but also Ghana, who are maturing towards a more UHC-based and are achieving 50-60% of coverage, that also the maturity of accreditation is running more positive because people with their insurance card can start demanding better healthcare. Now, as Farm Access, we're really proactively involved in that and seeing how can we promote universal healthcare coverage, and we can have a very much a semantics discussion about insurance versus UHC and what the difference is. But I think the very nature is it about making sure that there is equitable access and all people with a card can have an entitlement to go to healthcare facilities and seek healthcare and not have to worry about out-of-pocket expenditure and stimulate choice. And with that, you stimulate contracting, but you also stimulate prepayment for healthcare facilities. So one of the reasons why these healthcare facilities sometimes struggle is with everybody paying out of pocket, and it only takes a COVID crisis to scare half of the patients away, and the other half is overflowing the ICU department, but can't pay anymore because they lost their jobs, to disrupt how healthcare facilities are financed. So embedding better quality into universal healthcare care system and contracting for healthcare services is the #1 priority. Having said that, and especially for private healthcare facilities, investment is needed, and the amount of investment that is going to healthcare, especially on the African continent, is just way too low. It's, especially if you consider that it has about 25% of the disease burden. So it's disproportionately affected by more diseases, and we're spending the least of the whole world. And you're seeing that now again with vaccine rollout. We're forgetting this very big continent. Now, to stimulate investment, a couple of years ago, we also noticed that banks and investors are afraid to invest into private hospitals, because if they invest in a restaurant, they know that they can take away the kitchen or the tables or something else and resell it again. But if you invest in a hospital, you don't want to be taking away the X-ray if a healthcare provider is unable to pay back. And you might end up on the front page of the newspaper being accused of taking away healthcare of poor people. And in fact, you would be doing that, right? But these healthcare providers still need an investment. And this is where also SafeCare has come in. Banks don't speak the language of medical care. We can talk about outcome indicators and ANC visits and performance indicators, but banks think in terms of risk. And when we developed SafeCare as a rating methodology, filling the gap between licensing and accreditation. So on a scale to 1 to 5, we rate what is a high-risk facility and a low-risk facility. We rate what is a high-quality facility and a low-quality facility. You can still be lucky in one or another, but the risk of getting the wrong treatment in a high-rated facility is much lower. Now, this risk is also related to an investment risk of a healthcare facilities, and bank understands investment risk. They understand on a scale of 1 to 5 that 5 is lower risk than 1. And as a result, we started linking SafeCare rating assessments towards lending facilities for private healthcare facilities. And as such, it started functioning as a due diligence, guiding the risk of an investment, but also guiding the investments itself. Because I'm afraid to say doctors are great doctors. They're not always great business people. I'm sure the doctors in this session excluded, but a lot of them are not and can make wrong investment choices because they want the big MRI scanner when in fact they would be better off buying a new hematology analyzers. As a result of this, actually our loan portfolio through the Medical Credit Fund is the highest portfolio of the banks in general. So healthcare professionals are very reliable lenders. It's just that they never spoke the same language as finance people and quality people. And this is where a stepwise certification methodology, such as SafeCare that we developed, can also create a common language between these two parties, between insurance contractors, between banks, assessing the risk of doing business with the healthcare facilities, managing those risks, because sometimes realizing that the perfect hospital is not available where you are, and being able to finance that support. And as a result, also turning these healthcare facilities more into, I wouldn't call it a profitable business, but a sustainable, a self-financing business. My colleague always calls it a not-for-loss business, where at least healthcare facilities have income to stimulate in better quality improvement and have guided steps towards the same. And again, I think sometimes as quality people, we give healthcare facilities a report and tell them to do plan, do, check, act cycles and quality improvement plans, which are all very important things. But if, well, Jackie gave the example, is the generator is not replaced and you can't invest in a new maternal child department, yes, then you're never going to achieve that. So linking it to investments and starting building insurance systems where insurance systems start thinking about performance mechanisms to rewards better quality while also allowing investments in those facilities that need to get to that better quality, I think is going to be critical when we talk about sustainability, and it's going to be critical about addressing better health outcomes.
Thank you so much, Nicole. That was a very nice summary of the challenges that I think many facilities and certainly in Africa, but also in Asia are facing. And so the importance of investments to improve quality, I think no argument about it. One of the questions that we had, though, was about the accreditation itself. It's not a cheap process. We are talking about thousands of dollars probably as direct fees to the accrediting organization that also has to have revenue to survive, right? There are also additional costs, the whole process. If it's a multi-year process, I mean, you could argue that even that is an additional cost to the facility. Great outcomes, but it certainly requires resources. So can I ask the panelists, just quickly go to that point, how do facilities, either public or private, manage to finance the accreditation process itself? I'll start with you again, Jackie, and then Mohammed and Edgar and Nicole.
Yeah, it's a great question, Edgar, Eckhart, and certainly the cost of accreditation is seen to be expensive. However, my question in response to that is how expensive is a life? And if we're really going to provide good quality care, we have to make sure we put decent systems in place in all kinds of healthcare facilities. And the way we can make it affordable is if we're lucky enough to have donor funding, that so be it. I have a bit of an issue though, because I believe that donor funding can sometimes create a dependency culture. And I think we need to be thinking more about an independent culture where people are able to sustain their quality because that's the right thing to do, and that governments think about how they invest. And one of the big challenges in the affordability of accreditation is, as I said, the generator has not been replaced. Now, that actually is not an accreditation decision. You need a generator because the power goes off in many countries very often. And if you don't have a generator, your patients are going to die because the incubators won't work, because the lights will go out in theatre. It's just a basic. So what governments and all healthcare facilities need to do is to make sure there is a proper planned maintenance program in place that ensures that when you have this brand new building that somebody put up, maybe it was donated, but that you have a plan to maintain it and maintain the equipment. One of the big challenges in this continent as well is that we do not necessarily have equipment suppliers or engineers to maintain equipment. So countries may donate. I've seen an entire intensive care stacked up in a warehouse because it was the wrong voltage for the country. Now that is obscene, because somewhere else in the world, they think they've just saved Africa. And they didn't. It's just sitting there gathering dust, and because there is no maintenance plan, the equipment is used and then it breaks and it's gone. So I think we've got to start thinking about how we maintain what we've got, and then what is the cost of accreditation over and above that. And yes, there are costs, because I have to send a team of people, well, not now, maybe I only send one person, but a team of people on site for a few days, maybe 5 days, and that has a cost attached to it. But what we try to do is to be realistic at the start of the program, say, if you need to make capital investments, it's not going to happen tomorrow. So let's plan your program. And as Edgar said, it took them about 5 years to get from the start to their first accreditation. So be realistic in your planning. Where do you need the investment? The data, as Nicole was saying, you can do the PDSA cycles, you can develop your policies and procedures, you can get all of those things right, but then you need to have a realistic plan about what is the investment to get you to accreditation. And I always say to facilities that are coming into the program, this is not a sprint, it's a marathon, and you need to train for it. So take as long as it takes to get you there, as long as you're making progress on the journey, which I think was Nicole's point as well, as long as you're making progress and you're getting better, you're doing well. And the target is still there. You can still get there. We have payment plans. We have all kinds of different ways that people can spread the payment over a number of years to make it affordable. But the bottom line for me is, what are we doing to invest in good patient care so that African patients get as good care as an American patient, as a Dutch patient, as anybody else? And that we stop thinking that African lives are cheap because they deserve the best investment.
I love, and so does our audience, accreditation is not a sprint, it's a marathon. Great phrase. Mohammed, how about you from your perspective, as you are very close to hopefully being accredited, but how are you affording the process?
Actually, we still haven't started the process with Jackie. We are starting hopefully by the end of this trimester. But if as a doctor, I will ask the same question that Jackie has asked: how expensive is a life? But I will be very transparent. As an investor, as a shareholder, as a businessman, unfortunately, that is not a question that we believe in, sadly. But the question that I brought on the table was, how expensive is a non-operational facility that is aging with a non-sustainable income, because we are losing patients because our skilled team members are leaving and our patients will not have trust in our services in the future. Sadly, in the past, accreditation was a synonym of symbol of pride. It was a marketing tool. We have seen many facilities just bragging about themselves being accredited, having that logo all over websites, billboards, etc. There was no real belief in why are we doing this, why are we going through this process.
Yeah.
And I think with time, we have seen that it was very important for us to have protocols in place so that our SOPs are working and are regulating our daily operations without taking into consideration if today the supervisor is sick, away, on leave or not. Everyone knows what to do and how to do things. And if they have any question, they know where to ask that question and how to get the answer for it. So if you take it on a long-term perspective, whatever investment you are putting in will pay back. Will pay back because accreditation will tackle issues related to human resources, financial department, maintenance department, and daily medical operations. And that is very important because you will know when to do things. And basically, it's a kind of implementing a preventive management policy for the whole hospital. It's like when, for example, they ask us, why at Medland do you have a half of the floor dedicated to your biomedical engineer department with 2 expat biomed engineers that are training 3 local staff? Why do you need to invest in all this? Why do you have all these spare parts tools that are there? Simply because imagine if we didn't have that in times of COVID, we had machines that are breaking. What would we do? We cannot bring in, with all the travel bans, we couldn't bring in any engineer. If we didn't have that team and that preventive maintenance department fully operational in place, we wouldn't be there today. We wouldn't be providing in Zambia services that are not provided in the country or even in our neighboring countries, except obviously South Africa. People used to travel to SA or to India to have access to those services. Today, we are welcoming patients from Zimbabwe, Namibia, Malawi, etc. Why? Because we were ready in times of crisis. Why? Because we had those standards in place, even if we were not accredited. And I'm sure that there will be a lot of things that we have to enhance. But having that mindset in place. So if today an investor, or even myself as an investor, I will ask myself, why do I have to pay that much amount for accreditation? It's simply so that I can always be on the right track. And here, maybe I will answer indirectly one of the questions related to corruption, because yes, corruption is there, whether in private or public sector. Accreditation will teach you how to have different levels of control so that you don't fall into corruption traps. And it's very important because you will have, with COVID, for example, the many corruption aspects can take place in the supply chain. We have seen different examples in implementing a vaccination program, in implementing a screening program, etc. So it's very important to, again, have an organized preventive management that will, and I will conclude with that, that will in fact make you accountable for the vision and the mission and values that you have put on your folders, brochures, flyers, and websites. Because it's very easy to write a vision that we want to provide those services to everyone. That no, if we really want to be true with ourselves, and this is, for example, Medland, what we are doing today, we are trying to go into rural areas with the same level of quality care, because we have written that in our mission and vision. So if we want to be true with ourselves, we have, as a management, the mandate to find where we can gather those funds from. It is not the responsibility neither of the regulatory bodies or the patients or any other player to pay for that directly, just because we are saying that this cost has no income that is generated in a direct way. We have the mandate to find those funds and to use them to be accredited, and not to just brag about a logo on our website.
Thank you for making that point. Excellent. Actually, you have addressed one of the questions from Marilyn Keegan from COASA, who specifically asked, what are the savings when you become an accredited institution? So very important. And thanks also for addressing the issue of corruption. And I think that's a very important point, that being accredited allows you to better deal with that issue. I think that's something really important to bring out, because we don't hear that often. We hear a lot of complaints about corruption, but what you do about it, and that accreditation can be a solution, that's wonderful to know. Edgar, how does that look from a very large public hospital, which I had the pleasure of visiting when it was just constructed many, many years ago, and when all the equipment was still in boxes? But tell us a little bit more about King Faisal and the costs of accreditation, and also, did it save you something?
Right. I actually think that question has been very well addressed already, so mine will be very brief. When the process of King Faisal and the other hospitals in Rwanda that are in the program yet to be accredited started, I think we were lucky in the sense that the policy makers, the decision makers at the level of the Ministry of Health captured the importance and the benefits. And so for the first couple of years, even until now, our Ministry of Health has a budget line specifically for accreditation. So, I mean, we all agree that when you see value in something and it's a priority, you will prioritize resources for it. And that budget line has always been there to support the accreditation process, to cover the costs. The costs are definitely significant. There's no doubt about that. But again, the return on investment, so to speak, or for every dollar that we've invested in this accreditation process, whether it's the process itself, the facilitation and the fees, or whether it's the investments required to comply to basically have the required standards, whether it's in staffing, equipment, maintenance, infrastructure, technology, it's very, very cost effective. The return on investment is very clear. I think Dr. Mohammed mentioned that something about marketing and reputation, and also the fact that Medland gets patients coming from the surrounding countries, for example. And that's reputational. So we've been the same. We get several hundreds of people coming from Eastern Congo, the DRC, from Burundi, from Western Africa that come to King Faisal for care. And, you know, in 2019, before COVID, the hospital generated a significant amount of revenues from that medical tourism. And that's really reputational because people learn that, you know, this hospital operates with certain standards. And, you know, that actually brings patients. And when they come, they don't get disappointed. We've also seen that with, you know, like conferences and tournaments. Recently, we had the Basketball Africa League that had so many countries having a tournament in Kigali. And we provide the services, the medical coverage. So there's a lot of benefit that we've derived in terms of revenues from just being accredited. That reputation itself, but also the standards that are raised by the fact of being accredited. So I think, you know, you make it a priority, you plan, and I think as Jackie said, you make a budget for it, and then you get the return. The returns are very vivid, they're very clear. I think particularly for us at King Faisal, we've been used as a pilot in a lot of ways, although we are a fully government-owned hospital, but we have a certain level of financial autonomy. We don't rely on the Ministry of Health for everything. Actually, currently, the Ministry of Health only handles the capital investments, the heavy things. But since 2013, the hospital internally ourselves, we've actually financed fully the whole process of accreditation with COSASA. Internal budgeting, planning, approvals, everything has been done by us here at the hospital without involvement of the Ministry of Health directly. And that's because from the beginning of joining the program, there's a certain sustainability. I think Nicole called it not for loss. He used a very interesting term. So we've been able to build that quality, that standard, and that reputation, and build some financial sustainability that has actually permitted us to be able to fund the process ourselves. So it is sizable. The investment is sizable, but definitely if there is commitment and prioritization, there's no doubt about the return on investment. I think that's what I would say to that.
Great points, Edgar. Thank you. Really hitting it home about the return on investment. And Nicole was nodding in agreement. Just share with us what you agreed with in terms of what Edgar just said. And how does it really work for Farm Access? The term foundation obviously applies some altruistic and philanthropic element there, but do facilities pay to work with Farm Access? And
Great questions. I was nodding on a few things. First of all, return on investment, and second, I love hearing Dr. Edgar from a public hospital mentioning not for loss, right? Because I think a lot of donors, NGOs, and bilateral partners like to talk about sustainability, but then when sustainability translates into doctors like Dr. Edgar getting an income and being able to decide their own investments, then all of a sudden it's called for profit, and then people have warning lights left, right, and center. When I like to say, well, it's called an income, and we all have that at the end of the day, right? So you know, picking the fruits of this quality improvement and creating that ownership, I think is key to any sustainable program. We talked about return of investments. I'll share an example for you. I live in Nairobi myself, and when you go to the airport, there's actually a big sign from the Aga Khan Hospital. Aga Khan hospitals are one of the few accredited hospitals in Kenya. And it says you don't have to leave Kenya to experience international healthcare. And I love that picture because it tells you everything why an organization like Aga Khan Hospital is accredited, because they cater to people, expats like myself, and rich or at least middle income Kenyans that have the ability to get on a plane and go somewhere else, just as we heard from Dr. Mohammed and Dr. Adkar that they are also with their accreditation status or applying for accreditation status to achieve also that within Africa medical tourism that is very much around, because there's definitely better performing and worse performing hospitals. So who pays for accreditation? Very often the answer is the return of investment sits with patients that are able and willing to pay that cost of quality that ultimately translates into better health outcomes. Now, if people don't pay themselves, somebody else needs to pay. And unfortunately, the healthcare systems in Africa are so fragile that somebody has to pay for these people. Otherwise, they don't get quality of care. They're not able to pay for it themselves. So I think that is where the challenge comes in, and you can then question what the return of investment is of an international accreditation if you are the only facility in northern Nigeria with no one else around and really basic safety issues are the case. That's why also, you know, a lot of countries, I think, make the mistake of considering licensing a poor man's choice of accreditation. Get as a country your licensing system up and running, because that is what's supposed to prevent people from dying inside an hospital. That's where basic safety measures in place. And don't stop what you're doing there just because you're trying to get your main hospital in the capital city accredited. You need to do both, right? The King Faisal needs to be a center of excellence, but needs to inspire and also train young professionals that will staff the smaller healthcare facilities, and you need to regulate those by licensing. Now coming to the support, one of the things that we found as an organization, as an NGO, helping these healthcare facilities and being part of donor programs, is that sometimes, unfortunately, donor programs also do harm. We've had a lot of experience where quality improvement programs were supported by per diems and sitting allowances and fees. And a lot of healthcare providers are not used to paying for quality and seeing the value of that quality improvement. I'm happy to see the exceptions in this panel, but unfortunately, that's not the only case. So having healthcare facilities at least invest something, we have seen gives ownership, because it creates a client-customer relationship instead of free handouts where they can't complain if they don't like and it's not working. The moment they start paying a little bit for SafeCare or a little bit for COSASA, it becomes a transactional relationship where both have benefits, but also obligations to perform. Now, there should be subsidy obviously involved, and this is something where we as an organization try to drive in blended finance model where we mix subsidies, donor funding with at least co-payments on the patient, on the provider sides, but also in our universal healthcare coverage approach, the way forward should be subsidize the patients that cannot afford to pay, have everyone on the same insurance card, whether they're rich or poor, because then it doesn't matter anymore. For the Aga Khan hospital, if they need to cater for people that are able to fly out, because everybody in Kenya will be able to afford to go to the Aga Khan or another hospital of their choice. And then you also make quality evaluation systems part of a sustainability approach. And I'm now using very consciously the term quality evaluation system, because within that, accreditation fills a very important role, but we should never forget about licensing, about stepwise certification that we're doing ourselves, about quality improvement, and put that in a broader position, because all of these activities have a role to play and one should not be preferred over another one.
Thank you so much, Nicole. Great points. I just wanted to pick on something for the other panelists, and if you can give just short answers, a minute or so, about the measurement of quality involved, the systems that you have in place to monitor key components of quality, with either as an accrediting organization. What's the ongoing process, and from the hospital perspective, what are your key systems in place to monitor quality, and how do you report out, and how is that information used to make decisions? Jackie? and then Mohammed and Edgar.
Yeah, we've got a 4-scale scoring system. So we have a compliant, partially compliant, and fully compliant, or not applicable. And for me, the partially compliant is really important because it helps people on the journey towards compliance. It's not a pass or fail. It's about a journey from where you are to where you want to be and how you aspire. We also put a lot of store on evaluating systems within the hospital. What works for you or in your healthcare facility? What are the indicators that are relevant to you? Because we can come along and say you should count this, this, and this, but if they're not relevant to your system, they're not going to be meaningful. So they've got to be indicators that are meaningful within that establishment or within that health system, and that make a difference to patient care and make a difference to staff safety.
Right. Mohammed. You need to unmute yourself.
Exactly. Yes. Yeah. Exactly. What Jackie just said. You have to choose the indicators that will be applicable in your own facility. It doesn't make sense to bring in indicators from everything you have learned, and then you find yourself that they do not match with your facility. But in our case, since we are not accredited yet, it's more relying on internal audit. Just a quick one for Nicole, that's why I raised my hand. It is true that accreditation will enhance or will support bringing in more services to middle and high class society communities. That is totally true. For the poor people, I really believe that the same way this panel has brought in from a private sector perspective facilities, and I mean either from the public sector also facilities, but it has brought in another player who is the accrediting body. I think also we have to look at the supplying body because supplies into Africa are heavily priced, and that does impact the cost of service that we do provide to people. And that is also related to the fact that multinationals, they see us as a volume. And since this volume is not big enough yet, therefore the cost is high. If you take, for example, the percentage of cardiovascular services that are provided within the continent, they are very low, probably lower than what one country in the developed countries are providing. And therefore, the price of supplies are almost double or triple the price of what we can pay for in developed countries. And that is impacting so the level or the quality of care will always be the same. What we are not being able to do is provide some services to poorer people because they cannot afford that bill, simply because our cost of operations is very high. It relies on two things, the supplies, and also it relies on the trained and skilled team. And that is why training is very important, educating is very important. And for example, this is the only reason why Medland has applied and has been licensed a few months ago as an internship site in order to teach local skills and to train them over a period of few years so that they can be the team members that will lead a department. That will only reduce the cost, and that will allow us truly offering those services to poorer communities.
Thanks, Mohammed. That actually addressed one of the questions we had early on about continuing professional development. Herbert Schilthus asked that question. And Edgar, anything to add in terms of the role of continuing professional development within King Faisal?
Right. I think, as it's very commonly said, quality is a journey. It's never a destination. So it's something that's always ongoing. And continuing professional development is not just a requirement for accreditation, but it's also generally in most countries and in most professional bodies, it's a need, you know, whether you're a doctor to be licensed every year, nursing, midwifery, and all the other professionals. So we have both internal and external measures and platforms in place that ensure that CPD is ongoing all the time. And I think also you mentioned, so how do we actually monitor? I think that was your question before Jackie and Dr. Mohammed had answered. And, you know, obviously we are accredited by COSASA, so we have all these metrics and measures in place. We have a quality office that is actually represented at a senior management level. So every other week we have a senior management meeting chaired by the CEO, where one of the members actually heads the quality division. So this is very much part on the table all the time. And then one of the things that get people to monitor these metrics and make sure they're on top of their game is, you know, making sure that they produce regular reports. So every month, every manager, unit manager has to report on a number of criteria. If it's our accident and emergency, just a simple criteria like the waiting period. We look at the report every month and wonder, why do we have more patients waiting for 6 hours at the emergency room? Is it because results are taking long? Is it because, you know, clinical decisions are not being made on time? Other metrics in infection prevention control. So there's all these things that every unit manager reports on a monthly basis that we use to monitor, to give feedback, and to ensure that people don't slide back into bad routines and things like that. So there's all these different mechanisms, but ultimately it takes commitment and leadership. Otherwise, you know, you slip back invariably. But I think we've been able to keep up thus far.
Commitment and leadership, absolutely. Thanks for making that point. I want to give our other panelists 30 seconds. What's your vision, or what's your main take-home point from this round table when it comes to accreditation, universal health coverage? Jackie.
Thanks, Edgar. I think the most important thing is that this is about a continuous quality improvement journey, and accreditation is a tool within that. And it's all about ensuring that we offer people good, safe, quality services. It's not just about access, it's about good, safe, quality services. And it's a journey, and I'll repeat it, it's not a sprint, it's a marathon, and you've just got to keep on running.
Thank you, Jackie. Nicole.
Yeah, agreeing with that, and maybe I'd like to add as a sort of a next step, also thinking about quality and improvement and accreditation. A lot of these systems have been developed originally in the Western world, where we are relatively well financed when it comes to healthcare, and in the Netherlands there is a medical practitioner always within 10 minutes of a bicycle ride. If you live in Ethiopia or northern Nigeria, that is a very complicated activity and simply not feasible. So I think when it comes to quality and how we evaluate and how we recognize and how we improve, we also need to start thinking about incorporating digital solution and recognizing that on the African continent and in lower middle income countries, that sometimes translates such as that the doctor is not with you physically in the room, but can be connected to a medium and see you remotely. So I think as we lobby for quality evaluation systems in low and middle income countries, we also need to re-evaluate how we implement them, and quality assuring those innovations to be able to make sure that really everyone has quality care.
Very great point. Thank you so much, Nicole. Digital solutions, certainly during the COVID pandemic, has become extremely important and really allowing innovations to happen. Great points. Dr. Mohammed, you have the last word. What's your vision in terms of when it comes to quality assurance, accreditation, universal health coverage? 30 seconds.
Just to say that in order to really reach the UHC, we have to stop taking everyone's life for granted. I think COVID-19 has really helped us in knowing that we have to rely on ourselves. The vaccination problem is an example, and therefore, if we really want to reach the UHC, we will be relying on ourselves only, and therefore, quality, affordable, and accessible healthcare services are key in order to offer this to everyone with no exception.
Thank you very much for making that point, and really a great discussion. Thank you all for being such great discussants and making really interesting points. I hadn't thought about some of those, and thank you for bringing those up. There were some really memorable quotes here. Accreditation is a marathon, it's not a sprint. Quality improvement is a journey, it's not a destination. So, I mean, bottom line is we cannot talk about universal health coverage without also talking about excellent quality of healthcare that meets minimum standards. And thank you also for mentioning a lot of the supporting elements that create the enabling environment. So thank you again. Would love to do this panel again. Really great group. Finally, I want to thank the Corporate Council on Africa for organizing this roundtable, especially to its CEO, Flory Lieser, and also her staff, Moraya Essi, Josef van Joike, and Leah Treiber. So I'll hand it over to Flory again to give us some closing remarks. And thank you to the audience. There were a lot of other important questions. Unfortunately, we didn't have the time to address them all. There was one about the participation of patients and communities in the process of accreditation. So hopefully we can address those at a later point. Over to you, Flory. Thank you.
Wow. Well, thank you, Eckhard, and many thanks to our esteemed panelists for today's excellent discussion. Thank you to the audience and all the participants for being so engaging with your questions. I was going through and looking at them and thinking these are such excellent questions for this discussion and for the responses that our panelists gave. I hope you found the panel as informative and thought-provoking as I did. As we've seen in today's discussion, the private sector has an important role to play in accelerating progress towards UHC through accreditation of health facilities and medical laboratories in Africa. We've drawn great lessons and recommendations from our panel. Thank you so much, as well as the participants. And then we look forward to turning those into translating those insights into actionable next steps through CCA's health initiative, through work with our members, as well as our partners. Today's discussion touched on key issues that will also be addressed at CCA's US-Africa Business Summit, which will be held virtually on July 27th to the 29th. This year's summit will spotlight the next phase of growth in the US-Africa economic partnership, highlighting key areas such as health security, gender equality, trade, energy transition and climate change, agribusiness and manufacturing infrastructure, and digital transformation. The summit will feature 4 health sessions, I'm happy to report, which have been pulled together by the fantastic health team, Moraya Essi, Josef Wanyoke, and Leah Treiber. And they will focus on a range of issues that you all raised today and which are central to our CCA Health Security and Resilience Initiative. So we invite you all to register for the summit and join us for the excellent discussions we'll be having on health issues during the summit. On behalf of CCA, thanks again to all of you for joining us today. Stay safe and have a good rest of your day.